نبدأ بإذن الله. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome everybody to this session in the glaucoma series of Glaucoma Club in Sinjab Academy. I'm delighted today and honored actually to welcome Professor Gdih Gdih, who is working in Canada, University of Manitoba. Dr. Gdih, you know him very well in the previous series and in the current series as well. His lectures are very distinguished and they are characterized by being very simple, direct to the point, interactive, academic, and at the same time very teaching. So you find it at the end of the session, you will find a lot of things that you have learned with clinical applications. And at the same time, I'd like to welcome Dr. Basil Qaddura, who is glaucoma specialist working in Uddevalla Hospital in Sweden. He will be a co-moderator tonight in order to make the discussion more productive. So thank you both for accepting the invitation, and the stage is yours, Dr. Gdih.
Thank you very much, Dr. Sinjab. So I'll share my screen here and let me know, give me a sign if it's all visible.
Yeah, it's working very well. Thank you very much.
Excellent. So I would like to start the lecture with just a question to the audience. You have a post-refractive error or refractive surprise after routine cataract surgery with phaco emulsification and posterior chamber intraocular lens implant. What are the possibilities? So let's just see what how many causes we know of this. What could have happened here?
You can write, please, dear audience. You can write in the chat, please.
Yes.
So OVD, they're writing OVD one of the causes.
OVD, okay. I want to see as many possibilities as possible.
Yes,
OVD
exactly.
Behind the Iol, okay.
Exactly. Mm.
Yeah. I purposely want to pause on this to let everyone think.
Great. Because I have 3 causes in mind.
Okay, write them, Dr. Madsen. Let everyone or say them if you want.
Yeah, I'm waiting for the audience to write theirs. So I can cheat later.
Error in measurement. Okay, I like this. It's very significant.
Mm-hmm.
Okay. Dr. Ali Tsecha is writing malignant glaucoma with myopic shift.
Okay, that's good. Anyway, so the reason I brought this question because every time we see a myopic or refractive surprise after cataract surgery, first thing we go back to our biometry and look what happened. Okay, corneal edema, especially in the absence of other abnormalities, capsular block syndrome.
Actually, corneal edema or any haziness in the pathway will cause like wrong readings as hyperopic shift, not myopic shift, but false, of course, false readings. I would add, Dr. Gdih, as well.
Yes.
Improper sizing, not the power. I'm not talking about the power. Improper sizing of the IOL, especially in small eyes. Because when the white-to-white is small and we are using the traditional IOL, it will be inserted in the bag in a crowded manner. So it will go out, it will outbulge. The optic will outbulge because the space is very small. So the outbulging of the optic will cause myopic shift. This is why in small white to white, we have to use customized lenses with total haptic to haptic diameter, which is fit with this white to white.
Thank you. Okay, another question. Who have ever had a refractive surprise? If you had one in the past, write one. If you never had one, write two. I personally had. All right. So it seems like no one will ever can escape from this. Like everyone is going to face it. Okay, so let's move on now. So the common ones that always come in mind is Iol miscalculation, and that could be due to a condition that lead to a corneal or K readings error, or a condition that can lead to axial length measurement error. The one that lead to corneal K readings error, like a dry eyes, a prior laser vision correction, epithelial basement membrane dystrophy, cornea-related corneal warpage, Salzmann nodular degeneration, recent corneal manipulation, like applanation tonometer, or trauma. A scarring from trauma could also affect that. Therefore, in my practice, whenever a patient coming for their IOL calculation, before they get anything done, any pressure or anything done, first thing they get their IOL measurement. And then other conditions that can lead to axial length measurement error, it's like patient's fixation is poor during the measurement. So maybe more education and being patient and repeating measurements can be necessary. Globe contour abnormalities like posterior staphyloma, or eyes filled with material that can change the refractive index like silicone oil. Or sometimes can be the wrong IOL power implanted. That can be a human selection error, like instead of circling 18, you circle 19, or you write it down on a piece of paper and the nurse or whoever handle you the lens will read it, you know, by error. Or it can be a transcription, like if you say, you know, 15 and they think it's like 19 or something. So, or putting another patient's IOL, like you may grab the wrong, like the next patient's IOL and put it in the current patient. So all these things can happen, and it will happen to every one of us, regardless of how careful we are. There's also something called acute myopic shift, like ocular inflammation, trauma, diabetes, pregnancy, medication like topit. All these can lead to acute myopic shift. So I'm going to stimulate more thinking by just displaying this case, which is a 67 years old lady underwent uneventful right combined phacotrabeculectomy surgery. Her axial length is 21.3 millimeter. Prior to surgery, she was on pilocarpine for glaucoma therapy. On day 3, she was doing well and the surgery went well and everything is going great. On day 3, she woke up with sudden drop in distance vision and significant improvement of near vision, but no pain, no other concern. On examination, her visual acuity was 2200, but corrected well with minus 3 diopters of myopic shift. When revising the calculation of the IOL, everything seemed to be correct and confirmed. Her intraocular pressure was 8 in that eye, and slit lamp exam shows shallow AC, otherwise unremarkable. UBM was marked as normal, and no choroidal effusion detected or hemorrhage, and no retinal pathology. You don't have to say what's the diagnosis, but this is just this is a case that can present like this, and then we will come back to this case at the end of the lecture. So I tell my residents that 50% of glaucoma treatment is understanding the underlying mechanism and targeting the treatment accordingly. So let's all have a look at this. The above picture shows you the normal pathway of aqueous humor, where aqueous humor is formed in the ciliary processes, and then it travels in the posterior chamber and pass behind the iris, in front of the lens, through the pupil, all the way to the anterior chamber to fill it. And it goes all the way to the trabecular meshwork, Schlimm's canal, collecting channels, episcleral veins, and then the venous circulation. If we have any interruption in all this pathway, we gotta find that. I mean, if we have aqueous humor, it should go somewhere. Like the production does not stop unless we have a ciliary body shutdown. But if we don't have a ciliary body shutdown, so we have to follow the aqueous humor and find where that aqueous humor went. So if you have a shallow AC post-op, that means less aqueous collecting in the anterior chamber. Whether this is less formation due to ciliary body shutdown, or whether the aqueous humor is escaping the AC. If it is escaping the AC, let's track it and see where it went. So it could either go to the subconjunctival space, or it could go leaking, outside and just losing it, or it could go to the suprachoroidal space, or it could go to the vitreal cavity. So I always tell my resident, go find the aqueous, find its way. Where did it go? If we find the aqueous, then we will know what's going on. So after trabeculectomy surgery, if the aqueous went subconjunctival space, then we will find an overfiltering bleb or a high bleb. But if it leaked, then it's leaked. Then we have to fix the leakage. If it goes to the subconjunctival space, we have to slow down the flow by either placing sutures, tight sutures, or revising the surgery, or waiting it out. Many options are there. If it goes to the suprachoroidal space, sometimes it's hard to detect unless the person develops low pressure and then colloidal effusion after that, and then you can see them the retinal exam. But sometimes if they developed a small ciliary body fistula, then you cannot really tell where that fluid. You can't really tell. The suprachoroidal space is huge, and if the aqueous go there, it's sometimes hard to detect. Or it sometimes go to the vitreal cavity where it's hiding there, but because it's fluid, you can't really see it unless you have other indicators that it's going there to the vitreous cavity. So this is your thinking pathway after glaucoma filtration surgery. If you have a shallow anterior chamber, think of two things. First thing, measure the pressure. Is it high or low? If the pressure is low, then do the Sidal test. If it is positive, that means that's a leak, and then you need to repair. But if Sidal negative, think about choroidal effusion, and that can be diagnosed or excluded by B-scan, or aqueous suppressant, meaning the patient is not forming fluid anyways, so the ciliary body is shut down, or there is over drainage, and as we mentioned, you can tell from looking at the height of the bleb. But if we have a high IOP, first thing you want to check, if there is a patent PI or a closed PI or no PI. If there is no PI, then you think of pupillary block. If there is a PI and patent, then think of choroidal hemorrhage or malignant glaucoma. And again, high IOP also can be divided into a formed AC or a flat AC. Each one can be different. In the 18th century, von Grafé described a condition which we know as glaucoma, malignant glaucoma, as an aggressive form of post-operative glaucoma that was resistant to treatment and resulted in blindness in most cases, since the term malignant. I should say here, it's very important for us not to, when we share this terminology with our patients, to remind them that this is not a malignancy. It just the term tells the, it tells the prognosis of this condition being bad. But if you don't explain it, patients might go home and look it up and think that they have cancer or something. So that's important thing to keep in mind. And then shallowing of the central anterior chamber associated with increased intraocular pressure and normal posterior segment anatomy. In the absence of pupillary block and in the presence of a patent iridotomy and absence of posterior segment pathology. That was described by von Grafé in the 18th century. So the clinical findings of malignant glaucoma, first symptoms is often an improvement in near vision secondary to myopic shift in refraction as the lens iris diaphragm moves forward. Why the title of this lecture is that catch it before it bites you, because really it can bite you. It can present that way with just an improvement of near vision, and patients who like to read might like that and just not mention it. They might just enjoy reading, and then you can slip, the diagnosis can slip, and then you're in a bigger problem if you don't intervene early or early enough. It can be difficult to detect, especially when the IOP, especially before the IOP becomes higher, because it can start as early as, with the low pressure, and then the pressure keeps on going up. In most eyes, IOP is typically greater than 21 millimeter of mercury, but some eyes can be normal or even low. Also, malignant glaucoma has other names. They call it ciliary block glaucoma, or ciliolenticular, or ciliovitreal block, or aqueous misdirection syndrome, or posterior misdirection syndrome, or direct lens block glaucoma. So you can see it different ways in different articles. We must know what are the differential diagnosis of malignant glaucoma. Angle closure glaucoma, pupillary block mechanism with absence of a patent laser PI, choroidal effusion, plateau iris glaucoma, and suprachoroidal hemorrhage. They all have clinical features that can be distinguished, one from the other. The predisposing factors to malignant glaucoma are important to keep in mind, especially when you're doing a glaucoma procedure. Those things should be kept in mind, and the suspicion should always be high in this kind of patient's profile. If they have axial hyperopia, if they're nanophthalmic eyes, disorders of anatomical proportion in the anterior chamber, chronic angle closure with plateau iris configuration, or history of malignant glaucoma in the fellow eye. We see it in about 2 to 4% with history of acute or chronic angle closure glaucoma that have undergone filtration surgery. About 1.3% in glaucoma surgery alone or combined with cataracts. 2.3% in penetrating surgery overall. And women are 3 times more likely than men to have malignant glaucoma. It rarely occurs in non-surgical situations or spontaneously, especially in people who are on chronic use of myotics. So mechanism, it has been described by different people how this could happen, and no one really understands the exact mechanism, but some interesting theories like Schaefer and Hoskins, that posterior diversion of aqueous flow leads to accumulation of aqueous behind a posterior vitreous detachment, and then that will lead to forward movement of iris lens diaphragm and hence malignant glaucoma. Or they can have a valve-like mechanism by which the aqueous humor will go posteriorly, and that's why they call it misdirected, means it's going to the wrong direction. It caused the posterior diversion of aqueous, but the nature of the unidirectional valve remains unclear. Any fluid goes to the posterior side, posterior segment will never come back anterior. Hence the term valve. So we could see here with the diagram, it shows you that the fluid will escape to the gel, especially the front part of the hyaloid face, where you can have pockets of fluid and remain there, and the gel in between keep on pushing everything forward and causing this pressure rise. Anterior hyaloid obstruction with the other theory is that the breaks in the hyaloid anterior face could lead to posterior diversion of aqueous and then leakage of fluid through those breaks. Chandler also described the laxity of the lens zonules coupled with pressure from the vitreous leads to the forward lens movement. And the higher the pressure in the posterior segment, the more firm the lens is held forward, and hence the pressure rise in the eye. Now, this theory here, I think, at least from my personal experience, you know, I would say most of the cases that I saw in my clinical practice were pseudo-exfoliation glaucoma. So I think that supports this theory. Quigley also described that precipitating event which increases vitreous pressure is choroidal expansion, like the choroid expand and then pushes everything forward. And there's also called the final common pathway, where the transvitreal pressure cannot be equalized by outflow of aqueous humor. Then the anterior vitreous gel becomes less permeable to the forward movement of gel, leading to the fluid built up behind the vitreous, and then subsequently anterior displacement of the lens iris diaphragm. So what can we do in terms of imaging? We can order UBM, which if UBM has a challenge, you know, we don't have many technicians read the UBM very well, but if someone can detect it, you will see a swelling or anterior rotation of the ciliary body with forward rotation of the lens, iris lens diaphragm, and relaxation of zonular apparatus. It's easy to miss and mostly marked as normal UBM. We can also use the anterior segment OCT, which is similar to UBM, but it's easier to get and to approach to get access to. So once we diagnose malignant glaucoma, we should keep in mind that we have three stages of therapy. Either medical therapy, laser therapy, or surgical therapy. And when do we go to the next level? We can look at that. So when you start medical therapy, keep in mind you have goals to achieve. When you use cycloplegia is one of the treatment, either atropine or cyclopentolate. What you want to do is move the iris lens diaphragm backwards, and that will relieve some, give you some space. You also want to decrease the aqueous humor production, like beta blockers or alpha agonists or carbonic anhydrase inhibitors. Now, reducing the aqueous will not solve the issue, but it will help reduce the pressure and preserve the optic nerve during that time while trying to find a permanent solution. You could also shrink the vitreous body by using osmotic agents and oral agents like oral glycerol or isosorbide or intravenous mannitol. But keep in mind, when you use them in patients with diabetes or renal failure or congestive heart failure, you got to be cautious. Medical treatment works about 50% of the time. Sometimes indefinite use of atropine is required to prevent recurrence. Next is laser treatment. So laser treatment, you can use argon laser PI to access and diminish the volume of ciliary processes by argon laser ablation or undo ciliolenticular block. You know, how many times you have done an iris iridotomy, like a peripheral iridotomy, and then through that opening you could see the ciliary processes. It's very common, especially the temporal PIs. When you do them big enough, you'll be able to visualize the ciliary processes, and through that you can aim and target the argon laser to the ciliary processes and shrink them. You could also visualize the ciliary processes through a surgical iridectomy if you have, which you can access them and work on that. You could also, YAG laser can be used to break the anterior hyloid face to allow free movement of fluid in the vitreous cavity to enter the anterior chamber. So if you look at this diagram on the side, if you go to the peripheral iridectomy and try to make your anterior hyloid face disruption through here, you could enter these pockets, which tend to be peripheral. And then once that's interrupted, then if the fluid moves forward, the first sign you're going to see is deepening of the anterior chamber. And that's a sign that you have broke this attack, and patients can see improvement fairly quick. Also, you could use diode laser or cyclocryotherapy to shrink those ciliary processes by coagulation or cryotherapy to reduce that vitreociliary relationship. If all of that failed, then surgical treatment, which is pars plana vitrectomy with or without lensectomy. So the goal is to create a direct communication between the vitreous cavity and the anterior chamber. So typically you would go through the, this vitrectomy is that you would go through the, you can do it anteriorly going through the peripheral iridectomy. And then you could get through that fairly quick, and the picture changes from this side to this side. You can get, you know, anterior deepening, anterior chamber deepening, and then that will solve the issue. At Moorfields Eye Hospital, malignant glaucoma management, they reviewed 20 eyes requiring surgical treatment. So pars plana vitrectomy alone was successful in 67% of pseudophakic eyes, but it was only 25% in phakic eyes. So if you have a phakic eye, you probably need to do a lens removal. And then in combined extracapsular cataract extraction with vitrectomy with intact posterior capsule had a success rate of 17%, whereas patients whom primary posterior capsulotomy was performed, the success rate was much, much higher, about 83. what does this second point tell you? It tells you that the relationship between the posterior capsule and the anterior hyaloid face, that relationship is very important in the step of treating malignant glaucoma. So even though they removed the lens and did a vitrectomy, it did not solve the problem in many cases. The only success rate was 17%. But those who they removed the posterior capsule, the success rate jumped really high. That means that's where the most problem is. And then two eyes underwent primary intercapsular, two eyes needed the whole capsule to be removed in order to reverse the ciliary blockage. Okay. Also keep in mind the management of the fellow eye. If you have someone undergo malignant glaucoma, watch for the other eye. So what can you do? You can stop the myotic drops before undergoing surgery. You can prolong use of atropine after trabeculectomy, or avoid anterior chamber shallowing in the postoperative period by checking them more frequently. And if you detect that, you can use viscoelastic or tight scleral flap suturing in the surgery to prevent shallowing of the anterior chamber. My friend Dr. Varma and his colleagues in Toronto, they published a study on malignant glaucoma after cataract surgery. So what they found, they evaluated 20 eyes of 18 female patients. They were aged between 44 to 86 years old. They all treated initially with medical therapy. This was followed by laser anterior hyaloid face disruption, and also anterior chamber reformation, and intraocular lens pushback, and finally pars plana vitrectomy, all those who failed these measures. So what they found is 2 eyes responded to cycloplegia, 7 eyes responded to laser, YAG laser alone, and 6 eyes needed anterior chamber reformation and IOL pushback, which I will show you what that IOL pushback look like, where you go in with a needle and then you just push on the anterior face of the IOL and just push it back while you're forming the AC with a little bit of force. And I think they did that on the slit lamp, not even in the OR. And then 5 eyes required pars plana vitrectomy. So this is a picture of this needling for the AC reformation and IOL pushback. So in conclusion, this is malignant glaucoma remains a most difficult clinical problem in terms of diagnosis and management. Early recognition and implementation of early medical treatment may enable us to avoid the need for surgical measures and be aware of those eyes at risk from developing malignant glaucoma and follow them closely in the early postoperative stage. Thank you very much, and I'm open for discussion if anyone has questions.
Thank you so much, Dr. Gdih, for this is a very nice overview with all the mechanisms and the solutions for a tough topic that faces glaucoma surgeons. Actually, we do have a question from Dr. Yasser Sima. He's asking, how can we overcome the side effects of atropine when we use it indefinitely in some cases to avoid recurrence, as you mentioned?
Yeah, so we cannot avoid any side effect by continuing to use the agent, but I think that's a discussion you have. A person has to open that up with the patient if they are going to be permanently light sensitive, or they have a large size pupil if they are responding to the medication. But you have to overweigh the risks and the benefits. You can tell the patients, listen, this is preventing you from a condition that could lead to irreversible blindness versus living with a large size pupil and other side effects which can be monitored and treated as necessary. It is rare to require that, but it's a consideration. If someone has a really high risk or they have one eye to live with, then I would say that's a reasonable treatment option that you can discuss with patient.
Exactly. And I have a question. If you start with the atropine or cycloplegic, and as you mentioned, it doesn't work in all cases, but if it works, how long do you continue with the treatment? Not as you mentioned for avoiding recurrence, but as primary therapy.
Yes. Yeah, very good question. Yes, how long we continue with medical therapy before we consider other things? I mean, the same principles apply to any glaucoma procedure. As long as we don't have a iridocorneal or lenticulocorneal contact, we don't have a dangerously high pressure that's going to damage the optic nerve. And as long as we see progress, like if we don't see progress and things are not moving, patients still with a very high pressure and the anterior chamber continue to shallow, then I think it's a judgment call. You could continue on a long medical treatment as long as the patient's parameters are stable, like their pressure are within acceptable range, and their cornea is not at risk of failing endothelial failure due to a touch by the lens or by the iris.
Very nice. I'm just checking. We have no other questions, but I do have some questions, Dr. Gdih. I think Paul Foster, 10 years ago in Morpheus, published a series of 103 cases of microphthalmic eyes underwent cataract surgery. And he found that the shorter the axial length, the higher the complication rate. I think if it's below 21, was it 4 times higher? Below 20, was it 15 times higher, and so on. And the most, most important complications which happened were severe uveitis, malignant glaucoma, or ciliary dehiscence. My question is, do you consider doing primarily this IZH, iridociliary iridotomy, in the surgery, in the same surgery with eye that is lower than 20 millimeter or not?
Yes. Yeah, so that's a very good question, actually, and very practical question. Sometimes, and I'm sure many of you have seen this, when you operate on hyperopic patients or short axial length patients, sometimes in the middle of the surgery or towards the end of the surgery, you started to feel the posterior pressure and things are moving forward, and sometimes even hard to get the IA probe in to finish the cortical cleaning or to put the viscoelastic material to put the lens in. So in this case, you have, your options are either you stop, give mannitol and wait it out, or do something quicker to alleviate this posterior pressure so you can finish the case. So what I have done before, and I found it very practical. This is a fresh fluid from your BSS that you are using during the surgery, that it found its way to the retrolenticular space and started to accumulate and push everything forward. So I either take a 27 gauge needle, and with a direct visualization about 3 millimeters from the limbus, I will go in with an empty syringe and drain some fluid out. It's sometimes is enough to have like a 0.5 cc of fluid out that will deepen everything out, because it's just the fluid just got in there. There's no vitreous, it's just fluid. Get it out and then finish the surgery. And you probably want to finish it quickly enough, because if you take longer time, you're going to fill it again. And then get the surgery done with. Or the other option would be what you have mentioned, Dr. Basil, is that you go in with a pars plana vitrector and you do like a limited anterior vitrectomy to that space and deepen everything down. I found the needle is less invasive, and it works, and it's quick, and you don't really have to do anything different. So I found that very helpful, and it can be used. Or else you can abort the surgery, take them out to the recovery, give them mannitol, let the pressure come down, let the vitreous shrink, and bring them back and finish the surgery. Both options are, both options are available and can be done. But I found the needle one works really, really well.
Very nice. And about the pars plana vitrectomy, if you do it, or the pars plana approach, I mean, in short eyes, do you consider 3 millimeter, or do you consider 2.5? The pars plana can be a little.
Yeah, it can be close. Yes.
Anterior, yes.
Yes, exactly. So yeah, I would probably go about 3 millimeters. You can also introduce your retractor through the peripheral, through the zonules, like through if you have especially if you have an iridectomy, and most of these cases will have an iridectomy, a prior iridectomy before. So through that hole, you can go in with your retractor through the zonules all the way down to the anterior hyaloid face and get some fluid out using a retractor. That's also an option.
Yes, thank you so much.
You're welcome.
If the patient, I don't know if we have any questions, just a few comments. Thank you very much for informative presentation and educational as usual. They are thanking you for very nice presentation, Dr. Gdih. I have a question indeed. If the patient has already glaucoma and developed malignant glaucoma after cataract surgery, okay? So you decided afterwards to do either, pars plana vitrectomy or IZH. Do you tend to combine another glaucoma surgery at the same time, like angle surgery or another surgery, or do you prefer to do sequential approach, to do the core vitrectomy first or IZH and then glaucoma surgery?
If I understand your question correctly, you're planning to have a glaucoma combined with phacoemulsification?
No, it's a stable glaucoma patient.
Stable glaucoma patients, okay.
Yes, and undergo uneventful cataract surgery.
Okay, yeah.
And then after the cataract surgery, the patient develops malignant glaucoma.
Okay.
And you tried with everything, the atropine, the laser,
yes.
Everything, and didn't work. And you decided, now I'll go to the vitreous approach, and either pars plana core vitrectomy or full vitrectomy or the IZH. At this surgery, do you plan to it may be unstable in the future, or you tend to do sequential surgeries instead? Yeah,
a good question. It really depends on many of these malignant glaucomas that occur in routine cataract surgeries. These patients are non-glaucomatous, so they don't have glaucoma to start with. They just have a short axial length, and it happened for them. But if I'm not, if they have a mild glaucoma and I'm not planning to do a filtration surgery to them, I would probably want to dissolve the vitreous issue, because that's where the pressure is coming from. But if they have a significant glaucomatous optic neuropathy, and I'm worried that if any other reason they might get a pressure rise, I might consider a filtration surgery at the same time, just as a backup plan.
Yes,
That would be my approach, yeah. You know, I think the next person who is going to win the Nobel Prize for glaucoma surgery is the person that's going to find the way of how we can suppress the healing. Because our biggest enemy in glaucoma is the healing process, the natural healing process. I mean, you can have the fanciest MIGs in the world or the fanciest device and all, and they all work beautiful. And they even call it the honeymoon stage of glaucoma surgery. After the first 1 month, everything looks fine and the pressure is good and the blood is formed. And then the healing kicks in and disturb all that. If we look at any failure in glaucoma surgery, is mostly due to overscarring or healing. Mitomycin C has changed the dynamics in glaucoma surgery, but it's not enough. Like the success rate between the pre-mitomycin C era and the post-mitomycin C era is significantly better, like a significantly higher success rate in glaucoma surgery. So there is a chemical or a medicine that no one has yet pointed it out, and I hope everyone or at least the audience and the young ophthalmologists look into this, because that's where our glaucoma future is going to be, like to find that agent. Yeah, exactly.
Really great. Yes, we have some questions from the audience. How can we differentiate between malignant glaucoma and choroidal hemorrhage and colloidal effusion?
Yeah, very good and practical question. Colloidal effusion, if you remember the case that I presented, I don't know if you still see the lecture, but we can go back to it. We can go back to the case that I displayed in the beginning. Let's look at that. Okay, this case. So if you look at this person, they were nothing. I mean, it just woke up with a sudden increase or sudden decrease in distance vision and a significant improvement in near vision. But there was no pain, no concerns. They just come in and say, hey, doctor, my reading vision improved so much. That's the early stage. They may or may not have pain. Like in the beginning, they will not have pain. Later on, when the pressure goes really up, then they will get some pain and blurriness, like blurriness for both distance and near because of corneal edema and other things. And then you look, and then you will find the anterior chamber is shallow. The posterior chamber looks normal by fundus exam. You look, there is nothing, there is no choroidal effusion or hemorrhage. That's for malignant glaucoma. For suprachoroidal hemorrhage, patient in extreme pain, they will have excruciating pain that they will wake them up from sleep, or they will come right to emergency screaming from pain. It's severe pain that you cannot describe it. They cannot tolerate it. It's so severe because the bleeding happens in the nerve plexus and separated, and they feel all these short ciliary nerves are sensitized, and it's unbearable pain. And when you look in their fundus exam, you will see the choroidal hemorrhage is a dark blue posterior elevation of the choroid. Like it's more posterior, and it looks dark and dark blue, like grape-like. And that's the clinical feature. For choroidal effusion, they may not be symptomatic. They may have a mild pain that's not significant. And then when you look in the fundus exam, you will see this picture here, this one here. You see those choroidal elevations, which tend to be lighter in color because there's no blood behind them. They're just fluid, clear fluid, and they would be more anterior. If you look at the posterior segment around the optic nerve and the macula, everything looked nice and flat, and there's no dark elevation of the choroid. So those are this differentiation between those three conditions.
Yes, thank you so much.
You're welcome.
I have a question related to differentiating. You know, we have some questions from Dr. Ali Sheikha. We'll getting back to them, but how can we differentiate between malignant glaucoma and acute angle closure?
I stopped sharing, Dr. Ali Sheikha. Yeah, sorry, go ahead.
Yes, yes. In the slit lamp, how can differentiate between angle closure, acute angle closure, and malignant glaucoma? It is say the patient comes with IOB with 60, and just the slit lamp, the anterior chamber. Is it anything that can guide us to differentiate between the two?
There is, yeah. The biggest one would be the presence or absence of the patent iridectomy. If you have a patent iridectomy and the pressure is still high and the anterior chamber is still shallow with absence of other abnormalities, that brings up the suspicion of malignant glaucoma. But if there is no no iridotomy at all, or you have one that's blocked due to fibrin or lens material or something else, or blood, and it's not non-functional or non-existent, then that brings up the possibility of pupillary block mechanism, and that's more specifically in phakic patients. You know, a pupillary block mechanism in a pseudophakic patient is less likely.
Yes, exactly. Thank you so much. Dr. Ali Sheikha is asking if patients have malignant glaucoma for a long time after, I think he means IZH, with uncontrolled IOP. Would you go for Ahmad glaucoma valve or ATET?
If they have a long-standing malignant glaucoma, my aim would be to reverse that. So I would probably want to still aim for a pars plana vitrectomy and shaving all that posterior hyaloid face and making sure that I interrupt the relationship between the anterior hyaloid face, the ciliary processes, and the posterior capsule and all that area. That would be my intention or my goal. And then after that, and probably after that, if they develop a permanent damage to trabecular meshwork and pressure is still not clear, then yeah, probably I would aim for a valve implant instead of trabeculectomy because of the multiple surgeries and the high risk of trap failure.
Yes, exactly. There's a comment from Dr. Saeed. I think colloidal effusion, the IOP is low generally. Yes.
In colloidal effusion, the pressure mostly will be low, but it can be high. It can be high because, again, if we look at the anatomy, so I'm just gonna, I don't have the share yet, right?
No, you have to share again, I think.
Okay, let me, well, anyways, I mean, if the choroidal swelling happens circumferentially, you know, around the ciliary body, and that pushes the peripheral iris forward and block the trabecular meshwork, then you can have a high pressure.
Yes, exactly. I've learned, you know, to simplify the things again in your way, Dr. Gdih. I've learned something that if the eye is short and colloidal effusion happens, so there is no much space for the vitreous to escape, and this would cause malignant glaucoma, i.e., pushing all the things, you know, anteriorly. In myopic eyes, there is a lot of space for vitreous. So usually we don't face malignant glaucoma in those cases. But you know, there's no general rule in glaucoma. But this is what I learned to simplify it. Anyway.
Exactly. And as I said, I always, if you want to have there's no simple solution in glaucoma. But if you target the aqueous humor and find it, you will find the way. If you know where it should anatomically go, when the moment it's produced from the ciliary body to the moment it goes to the venous system, if you track that all the way and find it where it went, you will know how to resolve the issue. If there is no aqueous humor, that means there's ciliary body shutdown, and then that's another story.
Yes, exactly.
And the ciliary effusion or ciliary choroidal effusion and the or ciliary effusion and the low IOP, this is like the chicken and the egg. Which one came first? No one knows. I mean, there are theories that says, you know, due to inflammation of the ciliary body and that led to ciliary effusion and low IOP, and other theory says, you know, because of the low IOP, the ciliary body became inflamed and then become swollen. So we really don't know which one starts first. But steroid is definitely a consideration in this scenario, where you can target the inflammation and watch. Luckily, ciliary effusion or choroidal effusions are very reversible. Like they reverse on their own. We don't rarely need to intervene surgically for these cases.
Yes, exactly. Thank you. One comment from Dr. Basil. In rare cases, malignant glaucoma can be with normal IOP, as you mentioned in your lecture, Dr. Gdih, just
Exactly.
an anterior
Or even low. Sometimes that's why the title comes, catch it before it bites you. I mean, because it can really present in a low pressure, asymptomatic patient, and except for, as I said, you know, some symptoms are acceptable to the patient. You know, I had one of my early one in practice. Patient was happy. She said, "Oh, doctor, you did a great job. I can read so well." But that's not that's not what we want. Like, this is a problem.
Exactly, and especially in eyes when you have filtration surgery at the same time. So the aqueous finds another way, namely. Yes.
Someone asking your routine management of malignant glaucoma, please. Drops and general treatment, practical question. Thank you. Yeah, so I would put them on atropine. I would put them on steroid, you know, to minimize the inflammation. If they don't have a PI, I'll do a PI. Just to, but let's say this a PI is non-relevant here because this is malignant glaucoma. I would put them on aqueous suppressants. If they are on pilocarpine or any other myotic, I will take them off of that, and I will watch them carefully. If I have access, if there is a danger like a high pressure and I have a clear access to the anterior hyaloid face, I would take them to the YAG laser and start disrupting the anterior hyaloid face. And in these, you know, by experience, you need to use the highest power you have on your YAG machine. If yours go up to 15 millijoule, you gotta go that way, because it's really hard to disrupt the anterior hyaloid face unless you're using a very, very high power. And then watch it. You could sometimes solve it over the slit lamp with the YAG laser. Yeah, and then watch it over. You know, and then of course things will change. We'll divert from this if the patient develop a totally flat AC, or if they develop a very high pressure that's you know, putting the optic nerve at risk. Then a quicker intervention is needed, like a pars plana vitrectomy or something more definitive.
Very nice, thank you. I can't see any other questions or comments. So I think we have answered. You have answered all the questions and all the comments. So Dr. Mazen, if you want to comment.
Yeah. Thank you very much, Dr. Gdih, for the nice presentation as usual. It's It was so easy and very academic. Of course, we learned a lot from you. Thank you very much. Of course, I don't have any comment because I'm learning now. And I hope that all audience had the chance to ask their questions. And thanks to Dr. Bassett as well for moderating the session. Dr. Bassett, everything was covered?
Yes, very nicely.
Yeah.
Do I get a pass?
I think in the future, inshallah, we can issue certificates with CPD hours or CME hours. I'm working on that just for the attendees who attend. So in order to get those certificates, there will be at the end like a poll like a quiz, let's say, and then they can get the certificates. How about this idea? What do you think, Dr. Gdih, Dr. Bassett?
Yeah, I like that. I like it. You know, it's always, stimulation by questions is like a key in teaching. It keeps the brain working and activate, curiosity and looking for an answer is the way to learn.
Yeah,
exactly.
Super.
Dr. Mazen, I have 2 slides about the anterior approach of IZH. For me in the beginning was very difficult to imagine it. So do you think it's a good idea to just show them, just 2
Yes,
pictures?
Please.
Yes.
Yeah, please.
So this is a very nice book, very nicely illustrated by Ak Ahmed and his colleagues. The anterior approach, we start. You can start with the paracentesis and engage. If you don't have iridectomy in the beginning, you can do it with I-cut A mode, and then you can just go a little bit deeply with the cutting, just cutting to cut the Hiloid, the zonulus, and then the Hiloid. And then just, when you come back, try not to aspirate, not to, bring the vitreous with you while you cutting. Just, a few tips that can be helpful in this surgery. And of course, as Dr. Gdih showed, we can do it as well from the posterior approach.
Thank you very much. Yeah. That's very good, especially helpful in nanophthalmic eyes. Those
exactly.
Those are, whenever you start working on them, your heart beats is at the roof. Yeah.
And usually we are the glaucoma specialists who deal with such eyes, Yeah.
I was, telling that the first sign of suprachoroidal hemorrhage is the surgeon's heart rate goes up.
Okay, super. So thank you very much, Dr. Gdih, for the presentation and your kind efforts and for accepting the invitation. Thank you, Dr. Bassett, for the excellent moderation of the session. And I hope to see you all next month, inshallah, with a new session. And thanks to the attendees for being with us to the end. And hopefully, we can start issuing the certificates of attendance with CPD points in the near future. I'm working on that. Of course, this will need a lot of efforts, actually huge efforts, and a big part of those efforts are on the shoulder of the speakers, because we cannot issue or we cannot get the accreditation without their nice presentations in advance. So inshallah, we will work on that, and thank you very much. Next webinar will be next month. We will announce later about that. Keep an eye on my page on the Facebook, my own personal page, I mean, because I usually do the announcement on that. And you can, if you still haven't joined the Telegram, Sinjab Academy Telegram, please do that, because on Sinjab Academy Telegram as well, we do the announcements. Thank you very much, everybody, and have a nice evening for Canada and Sweden, and good night for everybody else.
Yeah, Dr. Mazen, I would like to thank you as well and congratulate you for such a wonderful platform that we learn from it across the world. And you have no idea how many people are using your website through just the good reputation, the high quality lectures, and the efforts that you put through. May Allah reward you multiple times for this effort. And I would like to thank you as well for allowing me to be a small part of this, which is really an honor and a pleasure. So thank you again.
It's an honor to me. Thank you, Dr. Gdih. It's an honor to me. And at the same time, I would like you to, all of you, to try SARSA and just tell me your feedback, because I think it's something of something, I mean, it's a core of something bigger in the future, inshallah.
Thank you very much. I introduced it to my center, Aqua Laser here, and the surgeons loves it.
Thank you. I appreciate that.
You're welcome.
Yalla, assalamu alaikum wa rahmatullahi wa barakatuh.
Assalamu alaikum.